Well, good evening, everyone. I want to thank you for joining for tonight's webinar, which is combating IBS, and that is combating irritable bowel syndrome. We're going to be taking a look at what irritable bowel syndrome is, and we're going to take a different route than maybe what you've commonly come to learn about IBS in terms of ways to deal with it, which can be a bit ambiguous when you start to look much into it. But for anyone that's dealing with IBS, you well know what an aggravation it is, how disruptive it can be to your life. And so what I want to do as we go through this presentation tonight is provide some insight and just a completely different pattern of thought of how to deal with irritable bowel syndrome. So that's all coming your way. But with that said, let me provide a quick intro for myself. I am Dr. Arland Hill. I've been in clinical practice for about the last 2 decades now. My focus is in chronic conditions and helping patients look at their nutrition, their lifestyle habits, exercise, anything that they have control over that they can modify that can improve their condition. Those are the things that we talk about and implement to help patients with. So with that said, guys, like I said, I wanted to dive into IBS tonight, and I want to give you some context of why I felt it was important to have this conversation for me in terms of what I'm seeing clinically, and that is that this condition has started to show up in my practice literally across the age spectrum. If I'm thinking right now, the youngest person that I know that I'm dealing with on this right off the top of my head is in the 6 to 7 year old range, the oldest individual in their 80s. And so the point being on this is that you'll see I'll point out some numbers tonight, and even when you look at statistics on this, some of the statistics say that this is more common in the decades of the 40s and 50s of life. But the reality is that that's just an average, and this could be applicable to anyone. And again, I'll share some more numbers with you as we go forward. But the point I want to make in bringing this information to you is that this is something that is troubling to a lot of individuals, and it's something that when we have an understanding of where it's coming from, how it manifests, there are definitely some things that we can do about that. Now, with that in mind, let's actually provide a proper definition of what irritable bowel syndrome is. This is best thought of in the context that we're discussing tonight as a chronic gastrointestinal disorder. Many of us, probably all of us, maybe better said, from time to time have had some acute irritable bowel syndrome, just where maybe you have a bout of diarrhea or you have some unexplained constipation that's not within your normal bowel habits, and it just doesn't make sense as to why that particular pattern is manifesting itself. That can all be more of an acute situation, and those things tend to dissipate relatively quickly. But when it's chronic, that's a different conversation, and there's some underlying dysfunction, there's some digestive dysfunction there that needs to be considered. And oftentimes from a symptomatic standpoint, we see that there's going to be some frequent abdominal pain, that there's what we talk about as visceral hypersensitivity, and that just means that it just seems like the bowels are more distressed than what they otherwise should be, even for the scenario that someone might find themselves in. It just seems like the pain or the discomfort that an individual has is worse than what would be necessarily anticipated. Gas and bloating are fairly common with these situations with the chronic irritable bowel syndrome, and not uncommon to have some indigestion along with that. Again, the dynamics, which I'll explain more, the entire dynamics and the motility in the gastrointestinal tract is disrupted, and that's something that we can actually do something about that, whether it's too fast or too slow. And then we deal with constipation in some individuals, but we also see that when it comes to IBS, there's these subcategories of IBS. So for example, we have what's known as IBS-C, which is IBS constipation, fairly straightforward. We have IBS-D, which is the diarrhea variety of this, if you will. Again, relatively straightforward. And then we have a IBS-M, which is mixed, meaning that individuals are alternating between constipation and diarrhea. And then we have situations where we have what's known as post-infectious diarrhea, where maybe someone had, for example, a bout of food poisoning, and it just, their bowels never seem to be quite right after that, and they roll into this scenario of IBS. Well, it's not just by chance that happened. There's a definable reason by which that actually took place. So that's what we're going to delve into. The severity on this between individuals is fairly broad. Some individuals, it's a low level annoyance, if you will, and to others, it can be just outright disabling. I mean, just completely debilitating. And so we want to acknowledge that. I mean, this is the scenario where we think about someone literally mapping their day out, looking at their agenda for what the day is going to be, and knowing how their bowels are going to respond. And they're literally planning their day around how can they get to the restroom in the event that they need to, because they know their bowels are that dysfunctional on a routine basis. And so in acknowledging that, I mean, clearly there is, if you're talking about changing your daily schedule, interrupting travel plans, anything that affects your social life in any way, that's a major disturbance to your life. And so we need to be thinking about, on a broad scale, where's this coming from? What can we do about this? Now, I want to also make a connection for you here, and I'll come back to this towards the end of the presentation. And that is to say that, and this is a bit of a clue as to where some of this dysfunction originates from, but that is to say that irritable bowel syndrome is not a condition that manifests in isolation. And what that means is that there are other comorbidities, there are other conditions, if you will, that are very frequently seen when we start talking about irritable bowel syndrome. And two of the ones that jump extremely high to the top of the list are going to be anxiety and depression. And I'm going to talk about, from a stress standpoint, how the stress component exacerbates irritable bowel syndrome. But I just want you to begin to register when we start making connections between the brain and the gut, and we step back and we look, and we've classically thought about these as two independent organ systems in the body, if you will. For example, the central nervous system and the gastrointestinal tract. And even in the conventional medical model, from a specialization standpoint, this is still the strategy, right? You have the gastroenterologist in one camp, and then you have the neurologist in the other camp, and they don't talk to each other. But yet we know that there is this very intimate connection between the gut and the brain, where there's this just constant crosstalk that's always occurring, and that if we ignore that crosstalk, then we do disservice to ultimately what the benefit to an individual could be. So we want to make sure that we're not overlooking that. Now, let's continue with a definition here, and this is where I'm going to get into a definition of where IBS actually sits. And it's what's classified as a functional gastrointestinal disorder, because literally and quite simply, the gastrointestinal tract isn't functioning as efficiently or functioning as optimally as what it should be. And in general, when we talk about things that fall under a functional gastrointestinal disorder, these by and large, it's a bit of a dumping category. And what I mean by that is if we can't officially tack a name to a condition. So for example, if we can't call it ulcerative colitis or Crohn's disease or some other specific gastrointestinal ailment, then many times it falls under this broader category of functional gastrointestinal disorder. And fortunately, now we know that there's particular areas of dysfunction that we should be thinking about when we look at this. But that is really, if you're thinking about IBS, that's really how you should reframe it in your mind. It's fortunate now because there's a trend in the research to actually delve deeper into this functional gastrointestinal disorder category, because it's not so clear-cut. The current or the previous research really hasn't given us answers. And unfortunately, when you look at the strategy of the current model, where it's symptom or disease based, these patients tend to fall into a category where they're not getting the support that they need. And so that's certainly an unfortunate thing, and that's certainly not where we want to see any of these individuals go, or that's not where you want to be if this is what you're dealing with. And maybe better to think about this in terms of IBS is that IBS is not a dysfunction. And this is one of the points that I'm going to emphasize as we go through. I've got a couple of slides that actually speak to this very point, is that IBS is a collection of different symptoms specific to an individual. And unless we delve in and find out what the root cause on these various symptoms are and what these various factors are, it's very unlikely that that individual is going to see resolution. So the word I like to use with this is multifactorial. IBS is a multifactorial condition. It's not driven by one line of dysfunction. It's driven by multiple lines of dysfunction. And if we ignore that, it can be a very dangerous path, because what we understand now is that IBS is, in one way, the tip of the iceberg. It's the alarm bell going off. And if these states of dysfunction are allowed to continue to manifest, they can escalate into other more advanced conditions. So, for example, they could escalate into autoimmune conditions where the immune system's starting to attack the body. And that's just one particular avenue that they can manifest into, but serious enough nonetheless. Now, I wanted to share this. I feel like it's important to make reference to what the current strategy is, and then where we can go, how we can go down a different road with this. So first of all, there are what are known as this category of peripheral agents. And so these are going to be things, and you'll see I have some of these categories I mentioned to you earlier, the IBS-C and the IBS-D. And so let me start with the IBS-D, because that's a bit easier. If you have an IBS-D where you're having chronic diarrhea, you may be recommended or prescribed an anti-diarrheal. Imodium AD is an over-the-counter that many individuals are familiar with, but that's a medicinal intervention to deal with that symptom, but not deal with the underlying dysfunction. Same thing as we talk about with IBS-C, the constipation, the laxatives being the more common intervention here. And then you get into these systemic agents, and these systemic agents are starting to tap into the nervous system. And what they're doing is they're looking at the activity in many of these of serotonin. And if you exchange the 5-HT that you see on the screen there for serotonin, serotonin is a compound. It's a neurotransmitter that has multiple roles on a neurological, social level. It's a neurotransmitter that helps us be more social, but it's also a neurotransmitter that is heavily concentrated in the gastrointestinal tract and can support motility. And so we can see from the standpoint of constipation, you would want a serotonin or a 5-HT agonist, something that's going to work like serotonin or support the activity of serotonin to enhance motility and to try to overcome that constipation. But in the context of IBS-D, where you're dealing with diarrhea, you don't want to do that. You want to do the opposite. You want to slow down that input, that motility. And so that's where we see these antagonists. And then you get into this category of antispasmodics. And I would actually say of all of the bullet points here, all of the strategies that are highlighted on this screen, the antispasmodics are probably the one that is the most prescribed. And these can be beneficial. I don't want to say that they can't. They do certainly have a place. And that may be that they just simply are helping to mitigate symptoms for a period of time until some of the strategies that we're going to be talking about tonight can find their place. So that was one of the reasons I wanted to put this in here, is to give understanding that this is not an either or. Sometimes we have to play both sides to ultimately find balance as we continue to evolve into a place where an individual has these various balance points in their life and their GI tract is functioning more optimally. Antidepressants, just take that back to the anxiety and the depression comment I made a bit earlier, the comorbidity connection there. Interestingly enough, many of these antidepressants do focus on serotonin. It's not the only mechanism that they can focus on there. But the interesting thing about that is that recent research has showed that this is probably not that great of an avenue to pursue when it comes to looking at supporting someone from an antidepressive aspect. You'll see that there's also some dietary interventions here, simply removing dietary intolerances. These could be things like fructose in the diet from fruit sugar. It could be lactose, for example, the sugar in milk. There's a couple of others that we're going to talk about here as well. And then low FODMAP. If you're not familiar with FODMAPs, I'm going to clarify for you what those are and give you a resource on that. But this is a category that can, in some individuals, act as an irritant to the GI tract. So we want to take these out. And then this microbiota modulation, this is an interesting category, I feel. And the reason being is that we do know with pretty good certainty at this point that there's an imbalance in the bacteria in the gastrointestinal tract when it comes to IBS. And there are the intervention with probiotics, and it's not any and every probiotic. There's a very specific strategy when it comes to this, but the intervention with probiotics can be very, very beneficial, and it can control the motility. It can control some of the sensitivity in the gastrointestinal tract, some of the inflammatory response that can be associated with this. It can mitigate some of that. And then there's these applications of these non-absorbable antibiotics, which simply means that these antibiotics, by and large, are going to stay locally in the gastrointestinal tract and perform their role. And you'll notice here that I mentioned rifaximin, and there was a reason that I did that, which I'm going to come to. And I'm going to show you a comparison on this where rifaximin was studied against herbal agents and show you what the outcome of that was. I think this will be interesting for you to see. Now, let's spotlight functional medicine here for just a minute, because I need to give you a backdrop of where our conversation is going here. And again, this is different than the conventional model where we typically see most viewpoints come from. But the idea here is that we're looking for personalized care. It needs to be specific to the individual. It doesn't need to be a consistent algorithm for every single person, that this is what you present with, this is the treatment that you get. That's not the mindset that we're coming from. We want to focus on the causes of the discomfort rather than simply the symptoms. What is the underlying cause here? And always, this is what I do when I work with patients. I'm always asking why. Why is that patient telling me this? Why is that presenting on their labs this way? Why did they respond that way to this intervention that I recommended for them? And if we can do that, it allows us to keep digging deeper and deeper and deeper until we can start to peel back the layers enough to actually get to the answer of where the problems are arising from. And from a intervention standpoint, the idea here is that we want to create a situation where the body has the capacity to self-regulate. So if we're talking about creating these habits that support the fundamental concepts of health, things like sleep and exercise and food choices and the environment around you, and looking at, what type of environment do you keep? What kind of company do you keep? All of these things ultimately play on our health, and those are all things that we have to consider. Now, let's transition into IBS here, and let's talk about some of the causes of IBS. And I really like this particular graphic because it lays it out very succinctly. We can easily see the factors that play into this, and you'll notice that there's 8 different factors that are shown on this particular slide. But just notice here, we have alterations between the interactions between the gut and the brain. We see that there is an increase in visceral hypersensitivity. That just means that you simply are feeling you're more sensitive to the feeling in your gastrointestinal area, in your abdominal area, than you would be otherwise. There are, as I alluded to just a few moments ago, there are some psychosocial factors that can play into this, and we need to acknowledge that the anxiety and depression connection is not, it's not by chance. There's a reason that that's there. Motility. A lot of times we've thought about, and I even showed you where we talked about antidiarrheals and laxatives. So if it's moving too slow, stimulate it. If it's moving too fast, slow it down. But the reality is that there are more defined control mechanisms in the body that we can nurture to optimize the motility and keep the motility working at a consistent rate day in and day out. There's mucosal immune function. What that means is that if you look at the inside of the gastrointestinal tract, you have this mucosa in there, these mucus secreting cells, and the immune system is nestled and layered all in that. And so if we're exposing that immune system to things that are going to make it more sensitive, that are going to make it more likely to respond, then that's going to translate throughout the rest of the body, and there's going to be an overall increase in inflammation. Not a good scenario. It's a slippery slope downhill once that starts to occur. Right on the heels of that, you'll see that there's increased mucosal permeability. This is where many folks, if you've ever heard the terminology of leaky gut, not crazy about that terminology, but it does illustrate the point. But I think we can do a bit better job in understanding that. The bottom line here is that the mechanism by which things are supposed to be inhibited from entering into the body from the gastrointestinal tract, that barrier system is allowed to be breached, which it should not be. There are many complications that arise as a byproduct of that. You can see here that alterations in the microbiome, we hear so much more about the bacteria and the fungal species and even the viruses and the parasites that exist in the gastrointestinal tract. And we ultimately are seeking out an environment that is homeostatic, that is balanced, that is creating a nice, even response throughout the entire body. And it doesn't mean that we create this sterile environment in the GI tract. It doesn't mean that we never have exposure to organisms that are less than optimal. It just simply means that the environment of the gastrointestinal tract should be able to maintain and keep itself stable and handle the occasional insult here and there, but shouldn't fall apart with these occasional insults. And then we can see food as a player in this as well. And we know that foods, for a number of reasons, can be problematic. So we'll, again, allude to some of those. Now, as far as some commonplace discomfort, this is where I told you I was going to put some numbers to this conversation. And IBS is one of the most underdiagnosed conditions in the United States. I think it's a relevant point to start out with that statement. But even when you look at this worldwide, there are approximately 580 million individuals worldwide that are dealing with IBS. So just to give context to that, that's about 1.5 times the entire population of the United States. And within that, it is still suspected that is still only half of the individuals that are dealing with IBS, that there is another 50% there that doesn't go reported. So you're looking at just under 1.2 billion people that are dealing with IBS. That's approximately 1 out of 7 individuals in the world is dealing with IBS. And again, this may not be something that they deal with year after year after year after year, and maybe something that they've been dealing with for a couple of months. And maybe it goes away and then it seems to remanifest. And so there's all kinds of different patterns of IBS, which is also probably speaks to a bit of why this has been given the maybe lack of attention that it has. Is simply because it's not as easy to define. There's just not this clear, definable state of what we would call pathology there, where there's just a disease manifestation process disease process manifesting. It just hasn't been as clear. The other problem in this is that there's a bit of a stigma around IBS. Like, for one, I know I see this with patients still frequently, and even after all the years I've been practicing, I still chuckle at this. When I ask someone to do a stool test, and they're like, "Oh, I got to do a stool test." Yeah, you got to do a stool test, right? So there's a stigma around that. But that information is valuable. And the point here being is that sometimes patients don't want to talk to providers about this. And there's just simply a lack of understanding when it comes to IBS, even within the professional circles. So there can be some obstacles to individuals getting help. They don't want to necessarily consult with a physician about this stuff. They're not necessarily forthcoming with their personal concerns about anxiety, depression, or other neuropsychiatric concerns that they have. And there's this general attitude that I still see this sometimes, where if you have some digestive discomfort, we just deal with it. That's just normal. Guys, that's not normal. Your digestive system should operate pretty efficiently. You should know you've eaten food. You should know about when you're going to have a bowel movement. You should have the bowel movement, and it should go pretty well. You should easily evacuate the bowel movement, and that's it, right? And you should know that pretty seamlessly. But individuals have gotten into this pattern where they don't defecate, and that's considered okay. And they get into a situation where they have severe abdominal pain after they eat, and it's told that it's okay. Those are all clues that something's going wrong here, and individuals are heading down the wrong track with this. Here's the other aspect of this that's worth noting here as well, is that this can be a bit of a difficult condition to diagnose. And I'll show you some exact components to this on the next slide of where we're going with this. But it's really diagnosed through the process of exclusion. It's not that you go in and you run specific tests that are exactly looking for markers aligned with IBS. It's the opposite of that. You're running markers to be able to rule out other conditions. And once you've ruled out the other conditions, then you're said to have IBS. If you couldn't fall into the category of these other conditions, you fell into the category of a functional gastrointestinal disorder, and that's where you currently find yourself. And so there's a bit of ambiguity that goes on with this, and it's a bigger category. It's an umbrella category almost, if you will. So that's part of the problem with this. And then if you start to look at some of the, like I said, diagnosis by exclusion, but if you look at some of the criteria, we have more symptom criteria, and then we have lab-based criteria. So, in the symptom criteria, if you're middle-aged, but again, that's an average. So you have extreme ends of the spectrum here. They're just as relevant. You have the young, you have the middle-aged, you have the old. Any age category can be dealing with IBS. If the weight's dropping, if there's some family history around gastrointestinal disorders, if there's a bleed, which is a big red flag, maybe someone has an iron deficiency anemia that there doesn't seem to be a great explanation for. These may be all symptoms that would suggest that someone is in a trend towards IBS. That's symptoms. On the lab side, you're going to be thinking about things like doing a standard blood count where we're looking at the red and the white blood cells. We want to look at these immune system cells and then the red blood cells and see how they're responding. Do we have a chronic state of inflammation? And we would pick that up with a marker such as C-reactive protein. There's other ones that could fall into that category also. Fecal calprotectin, this is an inflammatory marker that is specific to the gastrointestinal tract. It's oftentimes linked to inflammatory bowel disease, so not irritable bowel disease, but inflammatory bowel disease like Crohn's and ulcerative colitis. And if that's elevated, we would be thinking more along the lines of inflammatory bowel disease here. So that, again, helps us rule things out. One of the categories that's very commonly talked about when we start talking about IBS is gluten. There is much overlap between irritable bowel syndrome and gluten sensitivity. And this would even be into the category of what we call non-celiac gluten sensitivity. Sometimes individuals are put on just a trial gluten-free diet to see how they respond. And if they respond, then it's sometimes said that the exposure to the gluten and the potential for celiac disease may be the reason that they're having IBS. What happens when that individual doesn't have positive indicators for that, though, or they don't respond to a gluten-free diet? So those are all factors to consider in this conversation as well. And so the point being on this is that individuals can get into this merry-go-round, the medical merry-go-round of test and more tests. We didn't find anything at this appointment. Let's send you over here to talk to this individual, and that individual orders tests and they don't find anything, and then you go to the next one and the cycle continues to repeat. And all this really does at the end of the day is create frustration. And ultimately, as you will see as we continue to march forward here, more frustration, more stress ultimately leads to more dysfunction, because the neurochemicals that can support in balancing out these states ultimately are more and more challenged, and ultimately are driven faster and faster towards a lower level, and maybe even better stated as depletion, although we don't ever hit zero per se. but they're at levels that are inefficient to carry out physiological roles in the body, and they contribute to the dysfunction. So that ultimately means that we are at a point where we've got to reconsider the strategy that has been previously employed here, if you will. And I always like to have some evidence behind me when I make comments like I'm getting ready to make, in that we really need to start thinking outside of the box. Just the traditional mindset isn't going anywhere when it comes to IBS. And so if you look at what this particular article says, and this is specifically speaking to IBS and looking at a clinical review here, and this is out of the Journal of the American Medical Association, it specifically says that the management of patients with IBS is optimized, and note the key words here, by an individualized, holistic approach that embraces dietary, lifestyle, medical, and behavioral interventions. That is a sound, smart approach. It doesn't suggest that there is a solution, and it suggests that there are multiple avenues to pursue to customize a strategy that is ultimately going to work best for that individual. And so with that in mind, we can start to turn back to some of these functional gastrointestinal disorders. And again, we're keeping our conversation around IBS tonight, but what are some of the areas that we should start to think about when we come to these functional gastrointestinal disorders? Well, this particular article out of the Lancet actually defines these for us, and this is what it says. It says that there is a bidirectional dysregulation of the gut-brain interaction via the gut-brain axis. And what that says is that the communication going from the brain to the gut, that communication is aberrant, and then the communication going back from the gut to the brain, same problem. We're getting the wrong signals in, which ultimately means that we're going to get the wrong signals out. And the crosstalk becomes jumbled, and it becomes such that it leads and exacerbates a state of dysfunction, whether that state of dysfunction is immune dysfunction, whether that state of dysfunction is inflammatory in nature, whether it affects the hormones or the neurochemicals. All of these things are likely playing into that scenario. That's only one aspect of this, though. We also see that there is microbial dysbiosis. This is the altered microbiome in the gastrointestinal tract. This is where instead of having a nice anti-inflammatory commensal microbial profile, instead what we end up with is a situation that is exacerbating or pushing an individual in a direction towards disease. We see that there's altered mucosal immune function, visceral hypersensitivity, and abnormal gastrointestinal motility. So these are the things that we have to think about. These are the areas that we have to ask if you're an individual that is dealing with IBS. Am I looking deeper in each one of these areas? And if so, how am I doing that? And then what am I doing to stabilize these areas long term? And so I'm going to start to give you some hints here as we go through this. Now, what are some of the common causes? What are some of the things that start to stack up that can lead to IBS here? And again, remember, this is highly individualized. So there's the initial onset may even be different than the factors that drive the continuation of this condition. It doesn't necessarily stay the same, but there are a couple of factors that have ultimately been suggested throughout the literature to be consistent contributors here. So for example, poor diet. Probably not a surprise in me saying that. Poor diet can lead you down the road of disaster to about any condition that you want to point to. The integrity of the gastrointestinal lining not being stable and ultimately allowing exposure to various, whether it's food substances, whether it's microbes, whether it's environmental toxins. This opens the door for those to find a way inside of the body where all they can do is create harm and create problems. We can see dysbiosis. This is I've mentioned that word a couple of times, and I think this is probably one of those words that think back 20 years ago, the households of the country didn't know what gluten was, and now everybody knows what gluten is. And I think dysbiosis should fall into that same type of mindset, in that maybe today we don't know what dysbiosis is, but in 20 years, I would suspect that maybe we do know what dysbiosis is, and it is simply stated as an imbalance a lack of optimal balance of the microorganisms in the gastrointestinal tract. And again, this can be acute, it can be chronic, it can be influenced by bacteria, yeast, parasites. It can happen after a bout of food poisoning. It can even happen after a bout of a chronic virus. So there's a number of things that can potentiate these situations. Antibiotic use, as an example of one that can do it, and chronic stress being another. If someone is not finding joy, not finding pleasure, they just dread everything that they do, and everything feels stressful to them, and mentally they can't find for lack of better terms here, their happy place to ever find themselves in. Ultimately, that compounding stress is going to take a toll on the body, and it's going to impact the microbial profile in the gut. I was actually talking to a medical provider in Canada today, and this was a conversation that we were having. She was asking me, where is this patient's stress coming from? And the reality is that, for one, the things that this patient was doing, she was so regimented about doing all these quote unquote healthy things, that the healthy things and the agenda to do the healthy things had become the very stress she was trying to avoid, right? And so, if I use this example with her, I told her, I said, listen, doing yoga or some exercise like that may be great for some people, but don't ask me to do that. That's not what I want to do. It's not fun for me. It's not pleasurable for me. And I want to go do something else. And so each individual has to find out what their personal de-stressors are and start to implement those routinely to ultimately take down that stimulation into the nervous and hormonal system, such that we don't create this input between the gut and the brain, that we're constantly telling the gut from the brain that there's a chronic state of stress that is just persistent everywhere. What do you think that microbiota is going to do? It's going to change how it reacts to that environment. And in turn, it's going to start putting inflammatory signals back into the nervous system. And ultimately, what we're talking about with the leaky gut is that there are too many things that are being leaked through. So once these compounds are being leaked through, now we see that we're into a situation where there's an inflammatory response that comes from these. The immune system starts to attack these various pathogens. That's what the immune system perceives these as. And as a result of that, we start to go down this slippery slope where there's a multitude of dysfunction. So there's a breach in the barrier system, if you will. Now, from this, we should start to talk about SIBO. And SIBO has another condition that's gotten a lot more attention of recent, but this is small intestinal bacterial overgrowth. And interestingly enough on this is that some studies show that approximately 80% of people will suffer from SIBO. And that's a significant number. And there's some very specific reasons that occurs, but there's some things that tend to fuel SIBO. So for example, when you look at a diet that's high in sugar, or you think about alcohol, individuals that consume a lot of refined carbohydrates, and they notice when they eat those carbohydrates, and in very short time, they're starting to bloat, they're getting uncomfortable, maybe they develop gas from that. These are all factors. You look at antibiotics. We actually see both antibiotics and acid blocking drugs. There are specific situations in the medical literature where those are talked about as subsets of SIBO. So they're literally defined by the medication that the individual was using. Steroids can fall into this category as well. But one of the interventions that is often recommended here is going to be rifaximin. And this is where you heard me talking about the microbial balance a bit earlier. And I mentioned that I would show you this study. And within this study, you can see here that herbal therapy is equivalent to rifaximin for the treatment of small intestinal bacterial overgrowth. This study was actually carried out at Johns Hopkins University in Baltimore. But notice, you'll see what I've got highlighted in yellow here is that herbal therapies are at least as effective as rifaximin for resolution of small intestinal bacterial overgrowth by LBT, that's lactulose breath test. But also notice that you have this group of individuals who don't respond to the rifaximin. And so what do you do with those individuals? Well, Herbals also appear to be as effective as triple antibiotic therapy for SIBO, rescue therapy for rifaximin. So traditionally, when rifaximin doesn't work, the individual is prescribed triple antibiotic therapy. However, this shows us that there is an option for herbals to be effective. And specifically, I've listed two at the bottom there that are trade names. You can see FC-Cyto and dysbiocide. Those are two that I use in my practice. They showed in this study very specific outcomes here. And so clearly, those would be ones that we would want to consider if we can generate the same type of benefit as we've talked about with rifaximin. Now, in addition, let's talk about this diagram here, because this is the connection between irritable bowel and small intestinal bacterial overgrowth and how these two can start to correlate. And again, just to step back for a minute, when we talk about irritable bowel syndrome, an overgrowth of bacteria in the small intestine can be one of the drivers of that, and it's another degree of the dysbiosis that I talked about earlier. But you'll notice from this that we can see multiple pathways that are affected here. So for example, we can see that there, if you go up towards the right, there SIBO can increase methane, the CH4, and then methane can slow down the motility of the bowels. It can exacerbate constipation. Or maybe we go the other direction where there's a decrease in a compound called butyrate, which is a beneficial compound. It helps heal the gastrointestinal lining. It helps support the growth habits of other microbiota. But ultimately, what that can start to do is change the integrity of the gut lining to the point that we lead back to leaky gut or that increased permeability. And so bottom line, you can see there's multiple mechanisms on this by which SIBO could translate into irritable bowel syndrome, but this is at least from that dysbiotic perspective. If we're trying to make sure we're checking our boxes here, this is one of the ones that we should certainly be checking for. Now, in addition, yeast can be a factor in this. And so just like we talk about with the overgrowth of bacteria, we can also see overgrowth of yeast as well. And so we want to make sure that we don't ignore yeast in this conversation. We should be looking for that from a laboratory perspective, just as well as we should be for bacteria. And even parasites can be a factor in this. And this is where you could start to lead into this conversation around post-infectious bacteria or post-infectious irritable bowel syndrome. But there's a mindset that when it comes to parasites are third world issues. And that's not the case at all. It's not uncommon for me to run stool assessments with individuals and see that they're dealing with some type of parasite. They've been harboring a parasite, and ultimately the ability to alleviate that parasite can start to change the dynamics of the bacterial makeup in the gut to the point that it can start to restore some homeostasis, some balance to the gastrointestinal tract. So parasites shouldn't be overlooked either. Now, I mentioned this post-infectious irritable bowel syndrome. If some individuals, when we talk about this and I ask, okay, let's think back, tell me when this started. Okay, we've got a date. Tell me what happened before that. Oh, well, I went on a trip and I came back and things just haven't been right since I came back from that trip. High probability you're dealing with some post-infectious irritable bowel syndrome. And literally you can see as you start in the upper left here and you go from left to right, we go from eubiosis, which is a balanced state, to where we start to see that there's a transition into these dysbiotic states. And literally these different names that you see here, the clostridioides, the Bacteroidetes, the various organisms that you're looking at here, these are what start to become more predominant as these states of dysfunction start to get worse and worse over time. And so this should certainly be something that we should ask and think about as well. Was there a precipitating scenario? Was there something that happened just prior to necessarily the onset of your IBS that we need to factor into this conversation? Now, what about food intolerances and allergies and sensitivities and all these other things that we talk about? And there's a lot of confusion in these terms. And just to give a very simplistic approach to this, when we talk about an intolerance, this would be more along the lines of what we talk about with, say, lactose, like a lactose intolerance. Like because you don't have the enzymes or you don't adequately produce the enzymes to break that down, then you become intolerant to that food. So it's a immunological reaction to the food. Allergies are immunological, but they're more immediate responses. And sensitivities are also immunological, but they're more delayed in nature. Now, what I will share with you on this is that these can certainly be an impactful conversation as it relates to IBS. These can be precipitators to certainly very acute situations of IBS, but these can be difficult to pin down sometimes. And even when you're using testing, the testing definitely helps, but it's not perfect. So I don't want you to walk away thinking that. And it's also from a clinical standpoint, it's also why I like to try to create as much balance in the gastrointestinal tract as possible. Obviously, get the foods out that are inherently problematic, and let's see where we evolve to. And then if there's still concerns around food, then at that point, let's talk about looking at your allergies or your sensitivities and see what maybe uniquely you need to eliminate to ultimately find some balance there. And this is where we start to get in this conversation around with these tests of looking at antibodies. And these are beneficial. Again, I don't want to suggest that they're not, but this IgG that I'm going to talk about, it's the most abundant antibody in the human body. It's found in fluids everywhere. It helps us with both bacterial and viral infections, and it's one of the reasons, because it is so predominant, that we see that this is often looked at in terms of trying to understand what a reaction to a particular food is. But while that testing can be beneficial, just understand that there are some potential limitations to it as well. And so just keep that in mind as you're looking at this or thinking about these things. Now, as I speak to these antibodies, why is that so important? Well, when you're dealing with these antibodies I'm going to use the term antigen, which is a foreign compound. It can be a food, it can be a non-food substance. There's any number of things that can fall under this category of antigens that are going to be stimulants to the immune system. But notice in this category, we see that the more prevalent the exposure to these various antigens are, the greater the upregulation of the immune system to develop a response against the tissue within the body. And so here we see that there's anti-enteric, so that means GI, gastrointestinal, the enteric nervous system. So anti-enteric neuronal antibodies and irritable bowel syndrome. This study is highlighting that one of the mechanisms that could be linked to irritable bowel syndrome, and also one of the systems that could be dysfunctional, being the nervous system, may be in part driven by the fact that we have the immune system attacking the neurons in the gastrointestinal nervous system, which is also called the enteric nervous system. But think about that for a minute. The enteric nervous system is being attacked by the immune system, and as a result of that, the signals that would otherwise through the vagal nerve to stimulate the enteric nervous system to promote motility, to promote normal bowel contractions, that what we call peristalsis, that is not taking place. And so that can certainly be a factor. This is an autoimmune pathway, if you will. Pathophysiology is what we're talking about here. This is an autoimmune trend that we're looking at. And so certainly we want to take steps to try to offset and avoid this where that is feasible and where that is possible. Now, some individuals in trying to deal with this will go down the road of an elimination diet. And elimination diets, they can be a bit tricky. They can be a bit challenging, and you have to get pretty good at being able to listen to your body. So if you're not in tune with the response of your body to whether it's foods or environmental triggers or anything else, this may not be the best avenue, and maybe the testing is a better strategy for you. However, if you do have the capacity to be able to do that and acknowledge what some of these triggers are, then elimination diets might be beneficial. And so taking your diet down pretty narrow, and there's a couple of ways to do this. Many individuals that I've worked with have started to follow more of a high animal protein diet, just because you don't tend to have some of the same triggers in there that you do from other foods. And we follow that strategy for 2 to 3 weeks and get the immune system to calm down, and then ultimately start to reintroduce foods back in when we have more of a blank slate, if you will, and see what the responses are going to be there. And so by doing that, we can start to see when certain foods are reintroduced, maybe they cause a problem, maybe they don't. If they don't, we leave those back, we leave those in the diet. So there's different ways of approaching this, but by and large, that's the simple strategy for it. So getting the food out that's causing a problem can be of significance here. Now, I wanted to talk about within these IBS offending foods, there's 2 groups that are pointed to most aggressively, and these are by no means meant to be an exclusive list. So if you take these out of your diet and you're still dealing with IBS, it doesn't necessarily mean that food's not a factor in this. It can still be a factor for other reasons apart from just being a direct insult, okay? But with that in mind, gluten, which comes from wheat, and the main compound in gluten that we're looking at is gliadin. That is the gluten that is specific to wheat. But there are other triggers in wheat as well that can stimulate the immune system. So don't look at it and think, oh, well, I follow a gluten-free diet, or even I see now where we have gluten-free wheat that is trying to be brought to market. So don't be fooled by the fact that even if the wheat is bred in a way where, and no pun intended with bread there, but if it is crossbred in a way that they do ultimately find a way to eliminate gluten with that, there still are other triggers for the immune system. So don't let the wool be pulled over your eyes by that. In addition to that, you'll see that there is the FODMAPs. These are going to be fermentable foods, and they're different degrees of sugars of fermentable foods. So for example, or different lengths, I should say. So for example, if you start with these monosaccharides, those are very short sugars. They're 1 sugar compound. You take a disaccharide, it's a 2 sugar compound. You take an oligosaccharide, it's a multiple sugar compound. So different foods fall into different categories here. And then if you eliminate some of these, sometimes individuals will see benefit from that. And then you also have the sugar alcohols, and these are more of an interesting category maybe than they have been in the past, simply because individuals are more likely to consume these as a sweetener or as a non-caloric sweetener than they have previously. Now, let me talk about each one of these in just a bit more detail. And you'll notice if you actually start on the right side of this graph and work back to the left, you'll see as it relates to gluten, how the conversation tends to evolve as to whether or not this is actually a player in IBS. And removing gluten from the diet can be considered a first-line intervention. It's actually a good first-line intervention. It's a simple thing that individuals can do that may be directly acting as a trigger and promoting the immune response. It could be exacerbating the intestinal permeability we've alluded to. But there's some indirect mechanisms by which it could be affecting the gut as well. And so that's just a simple strategy of what we think about with gluten removal. Now, these FODMAPs, what I would say is that if you think about doing FODMAPs, and the way that I implement these with patients clinically is I start with a more balanced dietary strategy. We see how that goes. If patients don't respond from a dietary standpoint with that, then we take the next level, which is going gluten-free. And in general, I do recommend that patients follow that typical strategy. I don't recommend grains as a significant part of the diet. And then if we need to go to the next level, that's where we get into these FODMAPs. And so not to belabor the point around these FODMAPs, I would really just steer you to a document that I even use clinically with patients, which is from Stanford Hospital. And it specifically states what the FODMAPs are, which foods fall into the categories of FODMAPs, and even how to navigate a low FODMAP diet. So if you're, if you've made headway, but you need to, let's say you're 75% of the way there and you just can't seem to get over the hump on that last 25%, maybe this is something you look at. Maybe this is something you think about. You start looking at these dietary strategies and tweaking your diet a little bit. But again, there's multiple rationale for why IBS manifests. Now, I do think that this is one of the reasons that I use the more balanced diet strategy, and I create a balanced diet based on other lab information that I have with individuals to find out what their specific needs are, right? Is it more protein in their diet, or is it some other strategy that we need to try to support along the way? But notice on this, when you compare these three diet strategies against each other, what we see is that as far as adherence and outcomes, in terms of what the benefit is, they're fairly similar across the board. They're going to reduce gas, they're going to reduce bloating, the visceral sensitivity, hypersensitivity is going to decline. In general, there's less indigestion. So across the board, we're probably seeing an overall better quality of life with the intervention of any of these. However, when it comes to sustaining and maintaining these for long term, really the balanced dietary strategy wins out fairly significantly with most patients that have tried all of these. Now, let me transition to another factor that could be contributing to irritable bowel syndrome, which is this gut-brain axis crosstalk. And you don't have to look very long at this diagram to go, there's a lot of complexity in that diagram. And there is. And I'm not going to try to walk you through every aspect of it. But the bottom line on this is that when the autonomic nervous system is ultimately trying to control the enteric nervous system around the gastrointestinal tract and promote normal motility. If there is abnormal communication going from the gut back to the brain, then in turn, the autonomic nervous system and the stress responses coming out of the brain are going to in turn put abnormal input back into the gastrointestinal tract. So this is what we would maybe just simply classify as a vicious cycle. And we have to find a point at which we can break that vicious cycle. And ways that we can do that, we can find ways to improve the immune function locally in the gut. We can find ways to improve the permeability if someone's hyperpermeable, if the vagus nerve isn't responding as efficiently as it should be to stimulate normal motility in the bowels, or if the microbiota in the gut are imbalanced in a way where they're not nurturing the motility. These are all points that we can intervene and try to work on and try to address some of these shortcomings that the individual has. And remember, I'm talking between the brain and the gut, but there's truly another layer in this, which is the microbiota. The microbiota, they don't necessarily need let me phrase it this way. They can have direct input back to the brain. So we can have input going from the brain to the enteric nervous system around the gut to support the microbiota, but that communication is bidirectional. So it can work back the other way as well. Bottom line here is that you've got a very complicated interactive process that's occurring between how the brain communicates to the gut and how the gut communicates to the brain. Now, where do probiotics and even prebiotics, and I'll throw another term at you here, which is postbiotics, where do these all fall into the conversation? And they certainly have some very clear-cut support that they can do. Remember, I said that the microbiota clearly have been shown to, probiotics clearly have been shown to show benefit when it comes to irritable bowel syndrome, but it's not any and every probiotic that's going to actually do that. And also what we're starting to see is that we're noticing that the byproducts, some of the metabolites, if you will, that are produced by these bacteria are actually what are likely generating the benefit. And what that means is that it's not about simply having the organism there in significant concentrations. It's about the work that the organisms that are there are doing. And there's even instances where we see that lower dosages are more beneficial than higher dosages in terms of looking at improving clinical outcomes. And so that means that we don't have to ride this strategy of more and more and more probiotics. Maybe it's just simply, let's just give a little probiotic and let them do the work that they need to do. And that's a better strategy than just trying to overpopulate a gut, which may already have a population that's too great anyway. Now, you can see here just as an example on this, this was looking at a multi-strain preparation and multiple strains in this particular probiotic. And what we find here is that within an 8-week time frame, and this has been a consistent observation, is within about 4 to 8 weeks is when we see that the probiotics, when they're dosed correctly, not overdosed, when the selection for the right probiotics is made, within 4 to 8 weeks is typically when we're seeing outcomes. Now, we may even see that there's benefit beyond that, but by 8 weeks, we should be seeing some improvement here. And so that, again, has been a fairly consistent observation. And notice on this that the effectiveness, when we start talking about probiotics, can be species, dose, and disease specific and dependent on the duration. So again, it doesn't just mean the dose is not the only thing that's relevant on this slide, right? So more and more, again, most of the times, and when I talk to gastroenterologists and other providers about this, one of the acknowledgments that we all tend to make with each other is that you take an individual that has IBS and even especially IBS constipation, and sometimes you drop those probiotics in there at a high dose, and there's a high probability that individual is actually going to be made worse and not better. So we tend to shy away from going down that strategy with patients and use this idea that less is more here. Now, what are the probiotics doing? Well, I think this is an important question to ask. And notice on this that they're going to improve motility. So, for example, I like to use this mindset of the story has changed. An individual has constipation and they add fiber and the fiber shows improvement. Was it the fiber and the bulking effect of the fiber that actually did that? Or, as we know now, was it the fact that the fiber was actually a fermentable source to the bacteria, and the bacteria were able to make their metabolites, their secondary compounds, if you will, that ultimately enhance the motility of the gastrointestinal tract and help the individual overcome the constipation? So motility is certainly a big benefit for the gut bacteria. Activation of the immune function when it's necessary, better stated as modulation of immune function. We see that helping in improving the barrier function by producing these short chain fatty acids, and then ultimately providing adequate communication between the gut-brain axis. Now, that's everything that it should be doing in the right vein, but what about when these things start to go awry, or what are some of the things that can cause this to go awry? Well, you can see simply stated stress, diet, antibiotics. Even when we see that stress at an early age, what's the impact of stress at an early age? It's detrimental. It's very detrimental, and it can have a lifetime of effects. So we don't want to overlook the impact that does have. It may be something that we certainly have to consider. Now, just starting to wind down here, I want to give you one other point on this about these digestive enzymes. There is a little bit of suggestion that digestive enzymes can be of benefit when it comes to irritable bowel, but the truth of the matter is that this hasn't been heavily studied. But I think that anyone who has worked with this over any period of time can see by the mechanisms that we've talked about here that if someone is not digesting the food, and keep in mind that the digestive process starts in the mouth, which means sit down, chew your food slow, don't rush through your meal, be methodical with your food intake, and take your time. And if you do that, even the digestive enzymes that are starting to be released in the mouth, not necessarily just the ones that are released from the pancreas, can be more efficient in doing their work to ultimately allow the food that is going through the gastrointestinal tract not to be of a potential offending agent. So digestive enzymes are important. Also, when we start talking about balancing out the different microorganisms in the gut, the enzymes in the gastrointestinal tract are not simply meant to be there only for the purpose of digestion. They're also meant to be there as a defense line to start to knock down some of these microorganisms. So that's important to acknowledge as well. And that goes for not just the enzymes, but the acid and the bile that is secreted in the stomach and the upper small intestine. So important to not overlook that. Now, one last point that I want to make here is when we start talking about anxiety and depression, I want to go back to this, in that if someone is listening to this and you're dealing with anxiety, you're dealing with depression, and you find this dysfunction, this irritable bowel syndrome playing out, you have to acknowledge that there's a connection between those two, and intervening on one of those is likely to have a benefit to the other, but acknowledging only the GI tract and not acknowledging what's going on with the nervous system is a disservice, and you're not likely ultimately going to get to creating any true health for yourself without bridging that gap between those two. So what does this look like? Well, keep in mind that there is a multifactorial nature of IBS. This is the thing that I cannot stress enough to you as we conclude tonight, is that if you're dealing with IBS, you have to check each one of these boxes. These are the things that are under that functional gastrointestinal disorder category, these are the things that we're talking about. And if you can check these boxes, the probability that you will not be dealing with IBS is extremely high. And if you are still dealing with IBS, the probability that these have not been addressed adequately is likely your scenario. So think about that as you're looking at how do I set up a plan to try to manage this? How do I have discussions with providers around IBS? These are your talking points. So with that in mind, I want to thank you. I appreciate you coming on tonight. I hope that this information has been beneficial for you. And I hope that if you know someone with IBS, that you'll at least point them in the direction of this. This will be up on YouTube, so you can send them to my YouTube page and ultimately help them get educated and take a different perspective on this as well. And then if you want to know more about what I do, my overall focus on GI health and other areas of the body as well, you can go to drarlandhill.com. And I've spoken multiple times about food tonight. If you are looking for quality food that you can trust and that is uncompromising in the quality of it, and that will nurture you and support your overall journey back to health, you should go to harvesthillsranch.com. This is our ranch, my wife and I, Leah, and all the functional medicine concepts, all the health-related concepts that I've discussed with you tonight and that I've alluded to also go into the production of the food that we produce here at the farm. To my knowledge, we are the only farm in the country that is doing that. And so if you're looking for that level of food, you can go to harvesthillsranch.com and you can order directly there. You can have it delivered or we can ship it to you either way. So with that in mind, guys, I want to thank you for coming on again. I wish you the best in your journey of dealing with IBS. And if you were just here to learn more about your overall health, hey, even better. So again, thanks, guys, and we'll talk to you soon.